uh, go for any surgical intervention. We just drain the submandibular abscess, and the patient was gradually improved. This is another case. Positive tooth is the upper tooth and causes the infraorbital cellulitis affecting the eyes. This is the case of submandibular cases. This is another case of submandibular case, which was submandibular abscess, which was treated by surgical intervention. This is a pregnant lady about 7th month of pregnancy. Here you see there is severe buccal space abscess with severe form of trismus. The causative tooth is the mandibular lower right third molar tooth. And we go for surgical intervention and then remove the offending tooth. This is another case. She is referred from Kishore General Hospital, and there is fatal complication like the abscess involving the submandibular space, submental space, lip space, and there is also the sublingual spaces. We do the surgical intervention. There is surgical drainage, and then actually it was a case of infected odontogenic cyst. And after removing the subsiding the acute condition, then we go for surgery. This is another case of the buccal space infection due to infected oral squamous cell carcinoma, secondarily infected oral squamous carcinoma. This is another case of buccal space infection. This fair lady, the severe form of cellulitis involving buccal space, right buccal space and right submandibular spaces. This is operated by extraction of the offending tooth and surgical drainage, then proper antibiotic. This patient actually referred to our department from Ghorashal. There he took some treatment from general dentist, and the doctor extracted his tooth, but there is no history of surgical intervention to remove the abscess. That's why he faces multiple complication and is involved the abscess in different spaces like submandibular, buccal, infratemporal spaces and upper eyelid spaces. And he is also a patient of diabetic mellitus, and his diabetic level is very high, about 18 gram DL. So our proper treatment protocol for treating the deep neck space infection is proper diagnosis, identification of the causative tooth, extraction of the tooth, incision and drainage, proper antibiotic application, and then proper follow-up. Here the graph shows the frequency of the respondents according to the age. Actually, we get patients in different age. Every age is responsible. If his hygiene is below average, oral hygiene status is below average, to get different ages patient in our department. But fourth decade of life is more susceptible. This is pie chart shows the percentage of respondents according to sex. Male are more predominant, about 67%, and female 32%. Oral hygiene index. Most of the patients have very poor oral hygiene, having deep neck infection. Distribution of the respondents by anatomical locations of the abscess. Actually, the single abscess is very, we found single space abscess mostly in the submandibular spaces. Involvement of number of the spaces, one space involvement, total 66 patients, two space 5 patients, and more than two space almost 2 patients. Predisposing factors, mainly anemia. Anemia is, most of the patient is anemic and malnutrient in our department. And then diabetic mellitus, malignancy, liver disease, renal disease, and any other diseases. The patients having immunosuppressive drugs is responsible for predispose the deep neck infection. Organisms responsible for deep neck infections, actually it is the deep neck infection is responsible for mixed type of organism. There are different types of organism, gram positive, gram negative, anaerobic, etc. But most commonly found the streptococcus species. Etiological factors, regarding etiological factors in our department, most of the patients is due to the odontogenic cause, either carious tooth or broken down root, or there is previously treated maltreated tooth is responsible for the deep neck space infection. So my conclusion is poor oral hygiene status strongly correlate deep neck infection, which subsequently fall in odontogenic causes. In this regard, patients' motivation regarding oral hygiene maintenance, general dentist has an important role to prevent deep neck infection. By making an early diagnosis and provide appropriate treatment, we can easily prevent these fatal diseases. Last feature, this is another patient which is very fatal complication, which is this is not dessert actually. So thank you everybody for patience hearing.
Thank you, Dr. Farzana Sultana, for your valuable speech. Now I invite the audiences, those who have any question about any topic to the speaker. The speaker will answer from their places. Any question, please? So there is no question from any audience. I have got one question, one query, not the question actually, to Dr. Anwar Sadat. Did you,
yes, sir. Welcome, sir.
Did you use this frozen section, and for how many patients you practiced frozen section to clear the margin?
Thank you, sir. The question is the frozen section, how many cases? Exactly, I cannot give the data, as that is not my part of data. It is very necessary for the frozen section during the surgery in the primary site as well as the neck. And when I get the opportunity, I used to do the frozen. And especially the concept of frozen is clearing the margin. And we never solely depend on the frozen for clearance. Our clinical eyes, our brain, our knowledge about it is sometimes very necessary. But if I get the opportunity for frozen, I do the frozen.
Thank you very much.
You are usually doing this cancer surgery. So there's an imprint cytology and frozen section. Both are useful in case of margin clearance. Imprint cytologies. Did you do an imprint cytology or not? Only frozen section histopathology?
No, frozen. Only the frozen.
Thank you.
Thank you,
one
sir.
Question here. 1 minute.
Okay.
I have one question to Dr. Anwar Sadat. It's a nice presentations for that audience and the dental surgeon also about cancer surgery and its follow-ups. So when a patient came in our department, we are just biopsy to that of the patients from different places, from surgery or maybe the ENT surgeons are with them. The patient also have rights about the chemotherapy and radiotherapy. If it is surgeons decided that the case is inoperable, what may be done for your opinion for that of the patients? Patient is so poor, stage is advanced. Your ideal choice of treatment for that of the patients is it surgery or chemotherapy or radiotherapy combined?
Thank you, sir, for the question. And it is very important. You have highlighted one word, that is the inoperability. Inoperable. Actually, the term is inoperable is related to different aspects, and it depends on individual to individual, case to case. And if we think that patient can provide the treatment approach and we can do the surgery in any case. If we think that we can buy the surgery, we cannot make deterioration of the patient, we can extend the life as well as we can extend the quality of the life, that is important. Every case is operable. And if patient cannot provide the treatment like the surgery, we can do the non-surgical techniques like the radiotherapy and chemotherapy. But there is no question about the multidisciplinary approach. We can talk with the radiotherapist, chemotherapist. So far I have shown you one case that the lesion has extended to the skin and fungation of the skin. In that case, if we say that it is inoperable, what the radiologist or the oncologist can do? They cannot do anything by the radiotherapy or the chemotherapy. So it is you who can reduce, who can remove the lesion. And that everything depends on the multidisciplinary decision.
Thank you. Did you get your answer? Dr. Azam Khan.
The advanced cases, now patients is so aging condition, patients' guardians do not agree to do the surgery. So these cases, I just send the chemotherapy department, my chemotherapy oncologist.
No.
This is for satisfaction. We send the patient to the oncologist and oncologist used to do. If patient is not agreed, we have nothing to do.
I think as a little bit query that when a patient do surgery, it requires chemo or radio, both or only radiotherapy.
The decision of radiotherapy, for the oral squamous cell carcinoma, the number 1 treatment is the surgery. And number 2 is the radiotherapy, and number 3 is the chemotherapy. Radiotherapy is good, very good. After the surgery, you can give the radiotherapy. But chemotherapy, for the chemotherapy, there are so many factors which depends on the decision making on chemotherapy, like the distal metastasis as well as the histopathological grading of the primary lesion. If it involves the vascular invasion, then you can decide for the chemotherapy. There is some role of chemotherapy, definitely.
Thank you.
I think actually the matter of taking decision in case of cancer surgery, there should be multidisciplinary, definitely. The consideration of the, if possible, go through the cancer board, and decision will be taken after that whether it will go for direct surgery or preoperative chemo, neoadjuvant chemo, and then or radio, and then surgery, or after. Definitely surgery is the main stream of treatment in case of oral squamous cell carcinoma. If possible, then after that we have to go for radiation and chemo. Depending on that, the situation is created by this. But it should have to be discussed in the board whether we have to go for surgery or not. Some cases is not possible to, obviously. If patient is not want, then you cannot do this surgery. And another thing, we have to go through the board and decide that either it is possible to do or actually what will be the beneficiary for the patient, that we have to think about all the time.
Sorry, I want to add one thing with Dr. Bildur Rahman. That is about the board for cancer treatment. Board decided to give radiotherapy, surgery, then radiotherapy, then chemotherapy. Board already decided, but what happened? We do surgery and we refer the patient for radiotherapy and chemotherapy. It was seen even in the cancer hospital and Dhaka Medical College Hospital, patient cannot receive radiotherapy within the scheduled time, and patient is given chemotherapy first. Then whether the lesion is, by this time, patient can, maybe sometimes there is recurrence, and sometimes maybe patient's condition is very weak, and patient cannot go for the radiotherapy even. So this is the problem of our board and of our condition, socioeconomic condition, or due to lots of patients in our all departments like Cancer Hospital or Dhaka Medical College Hospital. We cannot provide the radiotherapy at first, though it is necessary for giving radiotherapy.
This is to me? Yes. Okay.
Yeah, so we should think about it. We should think about radiotherapy after surgery, though to implement the decision of the board.
About delay of the radiotherapy. This is the
it's a problem. Actually, if we think about the radiotherapy, but if we think about the surgery, actually we have to go for the clearance, margin clearance first, and then dissection. This is the prime stream of the treatment protocol. So if we think about this as a recurrence and residual, we should not consider the residuals. We must have to consider the recurrence. So if we think the recurrence, it will come after at least not earlier than, not after 6 months at least. So before that, before 6 months, it should have to be considered as a residual. We should not go for residual. That is the important thing for the clinicians, that if they will go for the surgery, must have to clear the margin and neck dissection as well. That should have to be considered maybe as a recurrent case, not the residual case.
Exactly.
Then it will be easier. Thank you.
Respected viewers and audience, we will be proceeding with the continuation of third session of the scientific seminar. Before that, I'd like to request our respected chairpersons to present the crest of honor to the respected speakers. I'd like to request Brigadier General Dr. Ghulam Muhyiddin Chaudhary sir to present the crest of honor to Dr. Nasiruddin sir.
Sorry for the interruption. I would like to ask, there was 2 topics on, one was orthodontic surgery, one was the distraction osteogenesis. So this, both of them are very close to each other, but selection of the cases, I have the query to Dr. Masood, I think. Did you consider the age and some of the pathologies like distraction before to orthodontic surgery, the condylar hyperplasia of mandible? So this is a pathology, sometimes it's coming to the, there was a long, did you consider the age?
Sorry? In case of orthodontic surgery, yes, age is obviously is a factor. In case of female, we know that developing stages from 16 to 18 years. So in case of female, we can do this surgery after 18 years. In case of male, the age is, developing age is 18 to 20 years. So in case of male, we go for orthodontic surgery after 20 years.
Another thing is that this, if there was a disease like condylar hyperplasia, it's a growing pathology. So
yeah,
if you go for early surgery, then it may be
condylar hyperplasia is another type of disease. For this condylar hyperplasia, obviously there is a facial deformity. So you go for, at first you go for the pathology. Then after removing the pathology, then wait 6 or 1 years, then you go for the surgery.
What to do in case of condylar hyperplasia, when there's a condylar hyperplasia, a patient came at the age of 15 years and condylar
then
hyperplasia,
you can do the condylar shaving or high condylectomy, then observe, okay?
And then you will wait for certain time and for the orthodontic surgery. Okay, nice.
Thank you, sir.
Thank you.
Thank you, sir.
My one question to Dr. Nasir about the distraction osteogenesis. How frequent you receive the complications related to this distraction? What types of complications did you receive?
For external distraction, we have seen as it was a first case, pin, when we are introducing pin, it introduced into the submandibular gland. It was one kind of complication. And later on, external infection, skin lesion, that was happened. And for internal distraction, for determination of vector is important. Sometimes vector determination is very critical in the same setting of operation, because 2 segments are mobilized. Then one segment, when the distractor will be activated, it will move according to the vector. If it is slightly different with the original plane, then the bone formation will be in a different direction. It will be a complication. Then we can cover it by giving elastic traction with the segments. That can be covered.
I would like to ask another complication that may, basically it is a very important thing, I think. If you go to osteotomy and there is a chances of injury to the nerve, inferior alveolar nerve. If happened the injuries to the inferior alveolar nerve through the osteotomy, at the first stage during osteotomy in the body of the mandible, how do solve this problem? What will be and how you can solve this problem in case of distraction osteogenesis once there was happened the injury to the inferior alveolar nerve.
Thank you very much. This kind of problem can be occurred, but we did not face this kind of problem. We overcome this problem by giving the outer cortex incision at first. Outer cortex incision and the lower border incision. Only outer cortex incision and lower border incision is sufficient. Then we give pressure with the outer cortex, and inner cortex is fractured. By this process you can overcome the injury to the inferior alveolar nerve. But if the inferior alveolar nerve injured, that is very hazardous for the patient, and that cannot be corrected simply without the nerve union. That is very difficult. So but we overcome this problem. We did not have any patient with the inferior alveolar injury or were sound.
How many cases did you do?
13 cases. One extraoral and 12 intraoral cases.
Do you select these cases when you are doing this, which one will be extraoral device or intraoral device? How do you decide
extraoral device, only one case we have done, and next time we started intraoral. As we have gone to intraoral, it is better for than extraoral, because extraoral is to bear a extraoral device. It is very difficult for the patient, and aesthetically it is not good.
Thank you.
I'm requesting Brigadier General Dr. Ghulam Mohiuddin Chaudhary sir to present the crest of honor to Dr. Nasiruddin sir. Please sir. আপনাদের সবাইকে করতালির মধ্য দিয়ে স্বতঃস্ফূর্তভাবে অংশগ্রহণের জন্য আহ্বান করছি। Now I would like to request Professor Dr. Qazi Bilur Rahman sir to present the crest of honor to Dr. Ajam Khan sir. I would like to request Brigadier General Dr. Ghulam Mohiuddin Chaudhary sir to present the crest of honor to Dr. S.M. Anwar Sadat sir. Now, I would like to request Professor Dr. Qazi Bilur Rahman sir to present the crest of honor to Dr. Abdullah Al Masood sir. করতালের মধ্য দিয়ে সবাইকে অভিবাদন জানানোর জন্য বিনীত অনুরোধ করছি। Now, I would like to request Brigadier General Dr. Ghulam Mohiuddin Chaudhary sir to present the crest of honor to Dr. Farzana Sultana. I would like to request the chairpersons of our scientific session, Brigadier General Dr. Ghulam Mohiuddin Chaudhary sir and Professor Dr. Qazi Bilur Rahman sir, to proceed the continuation of the third session of the scientific seminar. Thank you, sir.
Thank you very much. We have just concluded a session. Now we are going to the next session. In this session, our next speaker is Dr. Rumpa Wig. She will present about the topic Future of Dentistry, Bioactive Restoratives, first in the world. Dear audience, Dr. Rumpa Wig.
My salam to the dignitaries on the dais and of the dais, and my heartfelt thanks to the entire organizing committee, the core committee for BADI, for giving me a chance to share some knowledge which I have gained recently, because what I'm going to share with you is something that has just been launched in the world few months back. Indeed, a big honor for me. So, just launched worldwide, and I have the proud privilege to introduce to you in Bangladesh. Thanks a ton. Since the time is limited, I'm going to go a little speedily, maybe like a Tufan mail. Please be with me. And let's go ahead. It's a restorative. Now, I am mostly going to talk about a posterior restorative. Now, if we see a posterior restorative, what are the restorative options we have? Yeah? Once we embark on a case for a good posterior restoration, what do we have? The options we have are GIC, we have RMGIC, and we have composites. Now, if we see the GIC and the RMGIC, they have technically low tensile strength, they are brittle, and resistance to wear is low. So what happens? This kind of precludes their clinical usage in some load-bearing long-term clinical situations. Am I right? Yeah? Now what happens? Currently, the reigning king or queen for the restorative materials is composites. Let's do a quick check about what composites have to offer us. It's strong, highly acidic fill resins. Fluoride release is minimal. Yeah? They do not bond chemically to the teeth. They have a micromechanical bonding with the teeth. Hydrophobic. A very big disadvantage while working with it, they require bonding agents. Otherwise, how the tooth and the dentine and the bond interface will function? They leak at the margins, often seen, very common. If it is used in a thin area, they are brittle. They don't have that strong load-bearing capacity. Common problem while using composites is patient complaint, sensitivity. If you do a good big posterior composite and all, yeah, there's a sensitivity, and they tend to promote MMPs. What are MMPs? MMPs are matrix metalloproteinase enzymes present inside the tooth structure. Yeah? And most composites, they contain bisgamma. I'm not saying all. Yeah? But most of them have bisgamma, and which is a little controversial as a resin matrix, and which is the derivative of bisphenol A. Fine. Now, coming to the practical part. I'm a hardcore clinician, and I would like to do things in a way which makes my life easy. And so, what do you trust more while doing a posterior composite, while maybe etching and bonding? What do you trust more, enamel or dentine? Any answer from my dear audience? Enamel is better or dentine is better? Bonding wise. Dentine, enamel, okay, there's a mix. But technically saying, if you see the bonding substrate, enamel happens to be better than dentine. But fine. And here I'm talking about a big posterior cavity. That means the substrate we are working on is basically dentine.